So, you connect another. meeting
Kiran, can you please confirm if the screen is visible?
Yes, screen is
Thank
visible.
you. Thank you. Chinmay ma'am, shall I start the session?
Yes, please.
Thank you. Thank you.
Anuradha ma'am is there. Sorry, I can't see.
Yes, ma'am, she's there.
Yes, good afternoon.
Afternoon, ma'am. Afternoon, everyone.
Kiran sir, can we start the recording, please? Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar Series. We are starting with the series on National Guidelines for HIV Care and Treatment 2021. Today's topic is diagnosis of HIV infection in adults and children and assessment of adults and adolescents with HIV infection. From NACO, we have Dr. Chinmay ma'am with us today. Dr. Puri sir couldn't join. And the speakers for the session are Dr. S. Anuradha ma'am from COE MMC and Dr. Ramesh Adam from CDC India. We welcome you all for today's session and requesting Chinmay ma'am to kindly give the opening remarks.
Thank you. So very good afternoon, Dr. Anuradha and all the experts who are there, plus all the participants who have joined from different ART centers and different states. I take this opportunity to tell you that this is the most crucial and the most important topic when we talk about the functions of ART center. Because when the patient comes to ART center, the first thing that you have to do is how are you assessing the patient? If you can assess the person properly, half your job is done. Because by assessment, I don't just mean the clinical assessment. It also would cover the laboratory aspects. It would cover how much you are looking at the person's, his surrounding, his need, who is a caretaker, how the person is going to adhere to drugs. All these are really, really important. Is not going to adhere to drugs, just prescribing antiretroviral drugs or just, telling him once to go to a counselor and then going home. That doesn't solve the purpose. So therefore, how to assess a patient when you see for the first time? First time, number one, that's important. And also when the patient comes on follow-up visits. Because then only you can assess whether if he or she is adhering to drugs, whether they have any opportunistic infections or any other psychosocial aspects related to the person's behavior or the mannerisms also have to be addressed. So we are really fortunate to have Dr. S. Anuradha. She's a wonderful teacher, and I know like this, I'm sure at the end of this session, you will understand what I'm saying. The way she'll take you through on how to assess, that will be really helpful to you. So please pay full attention. And of course, a diagnosis of HIV infection is also an important part. And here we're talking about not only adults, but also adolescents and children. So please post all your queries and be mindful about how MAM takes us through the clinical assessment, the way you assess a patient rule out opportunistic infections, to the way you rule out other related comorbidities, because NCPs, mental health, all of these have to be taken care of. And also she'll take you through the WHO clinical staging, nutritional support, counseling, and all the information that has to be given to the patients. So with Dr. Anuradha and Dr. Ramesh, I hand over. So I hope to have a good session. So thank you.
Thank you, ma'am. Yeah, we'll quickly run through the pre-test. Requesting all the participants to please attempt the pre-test. Here's the first question. Please read the following case scenarios and answer the question. I'm reading out the case scenario and the e-poll will appear after I read out the case scenario. First scenario, adult person X has cough with expectoration for more than a month, fever for more than a month with severe diarrhea. Second scenario, adult person Y is asymptomatic and has laboratory report confirming HIV-1 infection. Case 3, adult person Z had history of extrapulmonary TB and molluscum contagiosum in the past and has a CD4 count of 350 cells per millimeter. Kiran sir, can I request you to please run the e-poll now? Thank you, sir. Requesting all the participants to please attempt the e-poll. Please read the questions carefully and answer the choices. These are single choice questions. So out of 4, 1 answer is correct. Please scroll and answer all the 4 questions. There are total 4 questions in all. Requesting participants to please quickly attempt the pre-poll. We would like to have a minimum of 70% participation for the e-polls. We have reached 25% participation. We have another 2 minutes for the e-poll. Only 44 participants have attempted till now. Requesting everyone to attend this, please. This is a long session up till 3:30 p.m. Please hurry up. Kiran sir, can you please confirm 40% have participated till now?
Yes, 40% is completed.
Okay. Okay. Ramit sir, do we wait till 70?
Let's continue, ma.
Okay. Sorry, continue with the e-poll or the session? Sorry, sir.
Session. Please.
Okay. Yeah. Thank you, sir. Kiran sir, we can end the e-poll now. Thank you to all the participants for attempting the e-poll. Requesting Dr. Anuradha ma'am to please continue the session.
Good afternoon, everybody. I hope I'm audible.
Yes, ma'am.
So we are going to talk today about two very important aspects of HIV care. The first part, which I shall be taking, is on the diagnosis of HIV infection in adults and children. And the second part of today's session will be on the initial assessment of a person who presents with HIV infection and how to go about from there on. So let us look at how do we diagnose adults and children with HIV infection. Next, please. So it is very important that we are able to diagnose patients with HIV infection in a timely manner. Timely meaning that we must have a very good clinical suspicion at the earliest possible time when patients present to us. It is important for us to do that because late diagnosis of HIV infection is a very important factor associated with immediate HIV-related morbidity and also with HIV-related mortality. In fact, one of the important causes for HIV-associated mortality is the fact that patients present late or patients are diagnosed late with HIV infection, and so they actually present to us with advanced HIV disease, which has a far higher mortality than patients who present early in the spectrum of disease. It is important to remember that HIV testing should always be voluntary and should be done after informed consent given by the patient and should be offered and encouraged across the clinical settings. In fact, it should be encouraged that when patients come into the clinical settings for any disease or any other morbidity, if we suspect patient could be having HIV associated HIV infection, we must encourage voluntary testing for HIV infection. It is also important to remember that the testing policies or testing strategies for HIV infection in child and an adult are different. And the reason for the difference is because of the obvious transmission of maternal antibodies to the child. And so we will deal a little bit about how to diagnose HIV infection in children also. And beyond 18 months of age, HIV infection for everybody, including children above 18, adults, adolescents, everybody, it can be detected by the presence of either the virus or the viral products like a viral antigen or an antibody to the virus that can be demonstrated in the blood or the serum or the plasma. And of course, in children less than 18 years of age, due to the persistence of maternally acquired antibodies, HIV diagnosis is made by qualitative PCR or polymerase chain reaction that detects the nucleic acid in the child's blood or serum. Next. So under the National AIDS Control Program, let us look at what are the important key points relating to HIV diagnosis. The most important thing to remember is that HIV diagnosis is based on rapid tests. It is very important to remember that rapid tests are the key to the diagnosis of HIV infection in adults and adolescents. And the rapid tests are based on the principles of enzyme immunoassay, immunochromatography, concentration, dot blot assays, vertical flows, and particle agglutination. These are the different types of results that you can get, but the tests are all rapid tests and they are done as part of HIV diagnosis in the program. It is important to remember that we do not use Western blot or HIV PCR or any of the other tests as diagnosis. We are only using antibody-based tests, test detection for antibodies using rapid tests. It is very important to remember this in the program. It is also important to remember that the tests that we use, all these different rapid tests, should have a sensitivity of more than 99.5% and a specificity of more than equal to 98%. This means if they have a very high sensitivity, there will be no false negatives, meaning we are not going to pick up anybody, we are not going to leave out anybody who has HIV infection. And a high specificity will ensure that only those who have HIV infection are detected as having an HIV infection, because there may be some rare situations where you can get a false positive HIV test result. Since it is a very life-altering diagnosis, we need to have tests which have very high sensitivity and very high specificity, and these are the tests that are used under our program. It is always important to keep in mind the concept of window period. The window period is that period of time that is represented by the period between when the patient acquires the HIV infection, that is, the HIV has entered into the body, but the patient's body has not yet been able to mount an immune response, which means the antibodies cannot be detected in that person's blood. This is variable for a period of 6 to 12 weeks. It is important to remember that if you test a person who is in the window period with an antibody test, that antibody test is likely to come up as negative, and you may be falsely assured that the patient is not harboring the infection, when actually he or she may actually be in the window period. So a window period test or a blood test performed during a window period may yield a negative result. So if you suspect that a person is in the window period, or there is a high risk that the person could be having an HIV infection, or the exposure to potential HIV related risk has happened recently, then it is very important to retest these people after 12 weeks. Usually by 12 weeks, the body will mount an adequate immune response to turn up an antibody test as positive. Next. So let us look at the diagnosis of HIV in adults and children who are above the age of 18 months of age. Now, India is a low prevalence country as far as HIV is concerned, though our case load is very high, the numbers are very high. Our prevalence rate is still very low. It is less than, it is very low. So in view of the very low prevalence of HIV in the country, it is necessary to use 3 different principles or antigen-based rapid tests to confirm the diagnosis. It is not enough to give a report of an HIV positive condition on the basis of one test. So all samples, when you collect this, it's also important to remember that when you collect the sample for patient from a suspected patient for HIV testing, all the 3 tests are performed on the same sample of blood, which means you don't keep on withdrawing samples to do the second or the third test. The first, the second, and the third test, based on different antigens, are done on the same sample of blood. The first sample of blood is very important, and we shall look at the logarithmic approach in the subsequent slide, but it is important to know that all samples which are reactive in the first test should further undergo confirmatory second and third tests based on the different principles or antigens using the same serum or plasma sample as that used in the first test. So it is very important to remember that the patient has to undergo only one prick or sample collection, but 3 different tests are employed on the same sample of serum or plasma. And the same blood sample is utilized for performing all the tests. There is also a possibility that the result may come out as indeterminate, which means it is it's neither clearly positive nor clearly negative, and the result may be given as an indeterminate test. All indeterminate testing should be repeated on all such patients on a second sample, on a fresh sample taken after a period of 14 to 28 days. This is the recommendation under the program. Next. So let us look at the strategy 3, which is the strategy under the program for diagnosis of clinically asymptomatic individuals, meaning the person does not have any symptoms related to the HIV disease, but the patient or the client has presented from the ICTC for a sampling. So the first assay, or the assay number 1, is most important. So you do a first assay. If the first test, that is A1, turns out to be positive, then you go further down the testing. However, if the first test itself is negative, you report that this patient is negative and you do not do any further tests on that sample, and you give a report of HIV negative for that person. Only when you have the first test positive would you perform the second assay, and then again you will see whether the second assay is positive or the second assay is negative. In case this first and second assays both are positive, you will go ahead with the third test. Now, on this, looking at the combination of the first, second, and the third tests, you can have these following combinations, which are to be interpreted in the following way. If all 3 samples are positive, that is the first, the second, and the third, all 3 tests are positive, the interpretation of that individual is, or that report is, that you report that report as a positive HIV infection, and that person is advised to undergo post-test counseling and further attachment or further referral into the HIV program. Suppose the first 2 tests are positive, but the third test is negative, then you give an indeterminate report, which means this person will have to be tested again after a period of about 14 to 28 days. The next scenario is that the first test is positive, but the second test is negative, and the third test is positive, meaning the second test is negative. This again is reported as indeterminate. However, if the first test is positive, the second test is negative, and the third test is also negative, if the patient is coming under a high risk identified, that if the client is coming from an identified key population, or the counselor identifies that this client who has come for pre-test counseling is high risk, then it is reported as indeterminate, or and the client is asked to repeat a test. If, however, the client is not considered at high risk, then this scenario of the first test positive, second negative, and third negative is reported as negative. So remember, when the second test is negative and the third is also negative, then one has to look at the risk profile of the person who underwent that test. If the risk profile is high risk, then you would report it as indeterminate, which means the person would be tested again. However, if the risk profile is low risk profile for HIV infection, then you would report it as a negative test and then send the report as a negative report. But remember, all these things have to be kept in mind. Sometimes you may want to repeat a test again on a person after a period of time, but again, please give a good adequate interval of time of at least 12 weeks if you want to repeat a test, so that if you think the person could be in the window period, then you are likely to prevent a false negative test from being reported. So this is the strategy 3, which is used under the program for detection of HIV or for reporting HIV when you get a sample from a clinically asymptomatic patient. Next, please. So let us look at the diagnosis of HIV infection in infants and all children less than 18 months of age. The earlier slide was about, yes, that is correct. Dr. Ravesh is saying that the earlier slide had a mistake and an error where it said intermediate. It should actually be on the right side. It says intermediate. Actually, it should be indeterminate. The box is correct, but the slide on the right says intermediate. It should actually be read as indeterminate. Next, please. So the most important confounding factor when you are trying to test for infants, young infants, newborns, or children less than 18 months of age is that maternally acquired antibodies to HIV infection, if the mother is HIV positive, can persist for almost 9 to 12 months. That is why we take a period of up to 18 months, where in very few cases they could still persist up to 18 months, but they are generally not persisting beyond 18 months in the infant. If an infant beyond 18 months has HIV antibodies, it is generally the result of the infection within the infant, and it's the infant's own antibodies which are present. Any antibodies present before that, say 6 months, 7 months, 8 months, are more likely to have been acquired maternally. That is why if you want to differentiate between maternally acquired and the infant's own antibodies, antibody-based tests will not be a good choice for this age group. So children born to HIV-infected mothers will test HIV positive for antibodies, regardless of whether or not they are infected with HIV. They could be exposed to HIV, but they need not be infected with HIV. So that's a very, very crucial difference to remember. So the National AIDS Control Organization recommends the use of what is called a total nucleic acid, a TNA PCR test, done on a dried blood spot, also called DBS, sample of an infant to detect viral nucleic acids for the diagnosis of HIV-1 infection during infancy. So during infancy, if you want to test whether or not an infant is likely to be HIV infected, then you would recommend a nucleic acid PCR on a dried blood sample of that infant. This test is first performed at 6 weeks of age. This is when the child usually first comes into contact with the health system, when the patient or the child presents or the newborn presents for the first round of vaccination. You can even do it earlier if the child presents earlier to the health system. But whenever the mother and the newborn come into contact with the health system or the healthcare workers, you would like to test the child for the first sample for DBS to be taken at 6 weeks of age. Secondly, you must at and after 6 months of age, again, if the child presents say after 6 months of age or around 6 months of age, again the total nucleic acid PCR must be performed after screening for HIV antibodies. And breastfed children are tested for the PCR 3 months after complete cessation of breastfeeding or after 18 months of age, whichever occurs later, to reliably exclude the HIV infection. Next. So it is important to remember that now that we have detected the antibody to the HIV in the sample that has been obtained from us, from the patient, we need to know what type of infection are we dealing with, because it has a significant impact on the outcome of the patient. HIV virus or human immunodeficiency virus is of two main types by classification. It is of HIV type 1 and HIV type 2. HIV type 1 is of three major types: type M, N, and O, which are major, new, and outlier. And each of these type M, HIV M, is further divided into different kinds of clades or subtypes from A to K, excluding one predominant, the HIV subtype in India of HIV-1 is C clade. So in India, the most infections are seen with HIV-1 M type C subclade, and HIV-2 has 5 subtypes from A to E. So it is important to know whether whether the patient is infected with HIV-1 or HIV-2 infection, because like I said, the clinical progression of disease and the response to treatment and response to antiretroviral drugs are different in HIV-1 and HIV-2. It is not important to know what subtype of infection patient has, because the subtype has no bearing on either the clinical presentation or the clinical response to treatment. So generally we stop at diagnosing HIV-1 or HIV-2 and we don't go beyond that for routine clinical practice. However, if you are involved in some kind of a biomedical research where you want to study the epidemiological pattern of HIV infection happening, then you may want to go down further to find out what subtypes you're dealing with. But as far as clinical practice is concerned, we stop at diagnosing whether the patient is having HIV-1 infection, HIV-2 infection, or co-infection with both HIV-1 and HIV-2. Next, please. So let us look. We saw earlier how we were diagnosing patients with suspected HIV-1 infection, but HIV-2 infection needs to be confirmed. So let us look at what happens, or how do we confirm the diagnosis of HIV-2 in a patient. Suppose a person or a client is referred to the ART center with an ICTC report, and suppose the first thing the ART center medical officer should do is to look at that report, to see the report and assess whether the ICTC report says that the person has the sample. The report will say either the sample found as only HIV-2 reactive by 2 differentiating testing kits at the ICTC, or it may say that the sample is found as HIV-1 positive and 2 reactive at the ICTC, or the ICTC may have done HIV-2 testing or reactivity status by only using 1 testing kit. In each of these 3 scenarios, we need to proceed further differently to establish the diagnosis of HIV-2 infection. Suppose the ICTC has actually performed the first type of assay where they have done HIV-2 reactive, that is only HIV-2 reactive, by 2 differentiating testing kits at the ICTC itself. It is reported as HIV-2 reactive and no further testing or confirmation is required for this particular patient. However, if a patient has both HIV-1 and HIV-2 reactive sample, then we need to send the sample further to a referral lab, designated HIV-2 referral lab, for confirmation that indeed HIV-2 is present. And of course, if only one kit has detected only HIV-2 reactivity, in that situation also, it should be reconfirmed by sending the sample to a HIV-2 referral laboratory. Next. So this is the flow chart for referring these patients for HIV-2 testing from the ART center to the reference laboratory. So those samples or those patients with an ICTC report where the specimen is positive for HIV antibodies, HIV-1 and 2, or only 2 in one test, and there is a particular referral slip, they from the ART center are referred to the designated HIV-2 referral laboratory. I hope and I'm sure that all of you are aware of which HIV-2 referral laboratory your particular ART center is linked to. because these linkages have been established very well in the program and they are functioning for quite some time. And so if you're not aware or if you're new to the program, please, you must make yourself aware of which is the designated HIV-2 laboratory to which your ART center is linked. There, a fresh sample of blood is collected, and again, a testing is done as per the national algorithm for HIV-2 serodiagnosis. The reporting is sent back to the ART center, both in the form of a hard copy as well as a soft copy is emailed. You retain a copy at the center and hand over the physical copy or a copy of the original report to the patient. So you are confirming whether or not the patient has HIV infection. Next, please.
Thank you, ma'am. Dr. Ramesh sir, requesting you to continue the session.
Yeah. Good afternoon all. You're able to hear, Sweta?
Yes, sir.
Yeah. So thank you, ma'am, for the first part of the session. And now we come to the second part where we will be looking into the assessment of adults and adolescents. The pediatric part of the assessment, we will take it in the later sessions. So this will be focused more on the adults and adolescents. And here we will see mostly what are the important physical history taking and trying to fast track patients on antiretroviral therapy, and what are the investigations that are really, really required to start the patient early on antiretroviral therapy. Next slide. Yeah, so this slide, if you are seeing, you will see that the first critical step is to have a good clinical assessment and taking a medical history. After that will be a physical examination and the baseline laboratory evaluations. But the first two steps are very critical in terms of they give us immense knowledge on how fast we could initiate this patient on antiretroviral therapy, or is that patient currently having any infections, or in the past, is there some history of any other opportunistic infection which you should be screening again, and is there any risk factors that the patient is towards any non-communicable disease. So these are all some key factors that we will be assessing from the clinical and the medical history. Physical examination, I will not emphasize again on this because this becomes a very important examination in order to rule out in which stage the patient is or there is any other underlying infection. So physical examination again becomes a paramount thing that before we initiate someone on antiretroviral therapy. Baseline investigations, yes, they are important, and we will see what are some of the ways how we could get these investigations fast tracked. Next slide, please. So the first is the clinical and the medical history, and why is it important? So as you know, first we need to stage the patient. This clinical staging helps us to identify whether the patient is progressing or whether he's having multiple OI. So this again becomes a very important clinical sign for us to say that the patient is improving or not in the absence of a viral load or a CD4 count in the initial stages of infection. So we need to know the baseline. What is the clinical staging? We will see the different slides on stages as we move forward. And to identify HIV-related illnesses, or is there any prior exposure to antiretroviral therapy? This is again very important in terms of not just the mothers who were exposed to nevirapine, but now we also have patients who could be potentially on a pre-exposure prophylaxis is another one important thing that the patients could be. And other thing is patient could have been taking antiretroviral therapy from the private sector itself. So in order to look at what are the options that we want to give the patients when he's coming to our facility, we need to really understand what is the prior exposure to the antiretrovirals. Then we also have to understand that not just giving ART, but to have any prophylaxis for opportunistic infections, it becomes very important to do a very thorough clinical examination. And so on for the nutritional status, past history and past illnesses, as I've already told. And this is last, but one is an important one, that is to understand the family members or partners. if you see the recent WHO guidance, it says that we need to follow a family-centric approach in terms of HIV clinical management. So when we look family as an index for treatment or for providing clinical care, what we see is we want to ensure that all the family members are tested for HIV. Or if they are not, we offer something called as a partner testing or an index testing, where we want to trace who all were infected within the same line. So this is another very important thing where the ART centers should start looking at the section 5 of the white card to understand what is the family history, whether there is somebody positive, or if there is somebody discordant, we need to again follow them after 3 months or 6 months based on their sexual history. So very important message to all of us today, again, through our new guidelines, what we are saying is we need to ensure that the spouse testing or the index testing practice needs to be taken up, not just for all new patients, but also for all the old patients who will be coming to us during every pill pickup. We need to look at the white card and see the family tree. Next slide, please. In the medical history, we also want to know the HIV testing status of not just the patient, but the family. And then the 4 symptom screening, definitely we will do to all patients coming to an ART center, irrespective of whether it is a due date or whether it is a stipulated visit or not, except for patients or a proxy patient, whoever is coming, or if there is somebody accompanying. So except them, we do for every patient the 4 symptom screening, and followed by general medical examination. And the history of ART again in the past is really important, because patients will not just, sometimes you have to proactively ask whether they are taking ART in some other place in a private sector. So that you need to specifically ask every new patient, because what we are seeing in the program now is patient is getting transferred out, patient is getting opted out, and as we analyze the data, what we see is they're actually taking in the private and again going back to some other ART center without coming to the parent ART center. So this becomes very useful information for us in order to give appropriate regimen to the patient. And a very important thing on substance use in terms of alcohol or IV drug use, and we need to give the counselors at the centers need to provide very proactive information on what are the side effects of these on when the patient starts taking antiretroviral therapy. And this again has a very important inhibitor role in terms of taking antiretroviral therapy. So if you look at patients who are not adherent, you will find that most of them also have an alcohol use, where they actually tend to forget to take their medication. So this becomes very important for us to tell them even before every new patient on these things, so that the adherence is not compromised in any way. Next slide. So if you see, this is from again our 2021 new guidelines, where we have divided how you need to take the medical history and the key components in terms of HIV testing. So we need to ask the patient to very actively engage with the patient and ask for what was the last date of the negative test they got, or the previous CD4 cell counts if they are available, previous viral load. And we shouldn't assume that somebody diagnosed today coming to a ART center for the first time and getting registered, that means in his lifetime he would have not taken ART or anything. So this is the reason we are emphasizing that past history of taking antiretroviral history. You can even, if you ask them further, they themselves will share you the CD4 counts if they have taken in the private sector, and they will give. So these are all again opportunities for us to counsel and to ensure that at least here the patient stays for a lifelong on the antiretroviral therapy. And knowing the patient's CD4 viral load status currently will also ensure that we rapidly put patient on antiretroviral therapy without waiting for these investigations at our end. Next, the HIV risks what the patient is having. For example, we have seen IV drug users. We have also seen other risk groups in terms of serodiscordant groups. So these are some of the very important things that we need to proactively ask the patient while we take the history. Then the third part is review of the clinical symptoms, where we actually, again, keep probing into certain questions related to 4-symptom screening. We need to, for the first time when the patient is getting registered or pays visit to the ART center, I think 4-symptom screening again is to be done with much focus, because what we are saying is even in the operational guideline sessions, we have told that IPT, whenever we are starting now along with the ART in most cases. Like it's not like the previous guideline where we told wait for 3 months. So it becomes really, really important for us to review the clinical symptoms of tuberculosis so that we may miss that. After that, we also have to take certain questions related to what is the psychosocial structure of that patient. For example, again, going back to the operational guidelines session that we had, and in the current guidelines, you will see that we need to assess whether the patient is depressive, he's elated state, he's anxious. So all these, there are certain tools that we have. So all those will be part of the pre-ART workup or pre-initiation workup that we will be doing. So those tools we should be using here. And then we ask about the past history. Any other intermittent infections that the patient had. Next slide, please. So then we go to the tuberculosis history and ART history. I already told you about PEP, PrEP history that we need to take. Very important thing that we usually miss is the substance use, and whether there is any sexually transmitted infections in the past, either through a good history taking, or we have to proactively again ask about the genital ulcers or lesions at the lower abdominal pain, frequency of that. So this becomes a critical part. And at the ART centers, the staff nurse and medical officers, counselors will look into more in terms of the adherence issues, substance use, and you can also ask about the ART history. So when the ART center works as a team, then each one of us can go deep into the pre-AR while we initiate a patient in all these aspects. Otherwise, just the medical officer, just the staff nurse, or only the counselor doing, number one, we have many patients at the ART center and we just say that we don't have time. But when we distribute this work equally with all the staff who are there within our ART center, then I think then we will be doing justice to take a very good medical history, and more on psychosocial aspects, the substance use, all these can be done by the counselor. Next slide. Right. Again, in the medical history taking, the other thing what we should also remember is the oral substitution, opioid substitution therapy. This again is for the IV drug use. So whenever we know that the patient is coming from the key population group, specifically with the IV drug use, then we need to ask about the OST practices, where they are taking these drugs. Now, all this will help the care provider at the later stage, if the patient is stable and if you want to refer the patient somewhere or to a decentralized drug delivery or a dispensation site or a CARG site, then we need to know this from the beginning, whether the patient is taking OST from somewhere else and ART somewhere else. So these are all the real challenges in the program. So unless we ask while we take a good critical medical history, we will not know. Then again, it becomes very important in sexually active group for a pap smear examination, where we refer, and a pregnancy and contraception history. So this again becomes very important to cross refer to other departments within the hospital whenever you identify something and you think that we cannot do everything to the patient, but a cross referral between departments. If you think that OBG or there is some gynecological issue that needs to be discussed. So these are the key things what we will be offering prior to ART initiation. Next slide. Next slide, please. Right. Then we have, yeah. Then after the medical history that we have seen, just to summarize most critical points which were not part of the previous guideline and what are all that we have brought here. Number one, you will see that screening for key population groups, and if there is no having a good family history and looking at the status of all the family members, referring for a HIV testing. And we are also seeing that how best we could take a medical history related to sexual STIs and then psychological status. Next slide. Yeah. So after summarizing the medical history, then we come to the physical examination. So physical examination, as you know, in the current guidelines, both in the operational and in the current technical guidelines, what we have seen, we have certain chapters on advanced disease management. Advanced disease management is not just having a lab test or a crack test in place, but to do a thorough clinical examination to identify any danger signs or any signs that needs a referral to a higher center, and not to put antiretroviral therapy as an emergency drug in those patients. So whenever we think of physical examination from now on, we need to understand that we are talking of categorizing a patient whether he needs an immediate referral to a higher center or where we could delay ART. If not, we need to rapidly start ART. So this clinical decision making will come from our general physical examinations. So as you know, first is general examination, where we look at the pulse, the respiratory rate, and then you also observe the patient, do a lymph node examination, oral cavity, skin, and then the system examinations as indicated. I mean, there's a reason. If you have seen the earlier part of the presentation, we told that physical examination, once you do at the baseline, it is going to serve the clinician and the patient. A very good rapport building occurs here when you start examining the patient. Next slide. So once we do a staging, we all need to understand what are we looking for. Is there anything specific that I'm looking in this patient when I do a physical examination? For example, if the patient is asymptomatic, so now we go into the clinical staging. Before we go into clinical staging, what we need to understand in a broad sense is stage 1 is actually nothing. That means the patient is asymptomatic and or they may have a progressive generalized lymphadenopathy. That's it. There's nothing other than this. And if you think of how do I remember stage 1, 2, 3, 4, this stage 1 is easy asymptomatic. Now you directly go to stage 4. Stage 4 infections mostly they require a laboratory diagnosis. For example, if you are saying now cryptococcal meningitis, I cannot just simply say that from the air. I need a lab support. So you say toxo, it needs a lab support. You say PMLE, it needs an imaging support. So most of the OIs that require diagnostic workup and where we can only make the diagnosis with the help of a laboratory workup in most circumstances. Now, there are still some examples of stage 4 conditions without a laboratory support, but majority of them require a laboratory support. They are all under stage 4 conditions. Stage 3, you will see mostly the skin related infections fall under the stage 3, and our TB and some known infections are in stage 3. If they are disseminated, they go into stage 4. For example, if TB, just pulmonary TB is stage 3. If it is again a disseminated or an extrapulmonary TB, then it goes to stage 4. If it is just oral oral thrush, it is stage 3. If you have an esophageal candidiasis, it's stage 4. So that's how, based on the degree or the dissemination of the infection, number one. Number two, based on the diagnostic support, that means they are really infectious diseases that require lab support, they are in stage 4. And what we see mostly, the skin related dermatological infections are majorly categorized in stage 3, and stage 1, as you see now, as we speak in the current slide, it's just asymptomatic or having the persistent generalized lymphadenopathy. Next slide, please. So you see on your left are all the stage 2 related conditions in adults, and on the right are the in children. So as I told you, mostly these are all herpes zoster, angular cheilitis, oral ulceration, PPE, fungal nail, seborrheic. Mostly these are all skin and dermatological manifestations. And similarly, you will see in children too, but you see like extensive wart, extensive molluscum, gingival erythema. These are again not part of the adult clinical staging. Next slide, please. Yeah, in stage 3, again, you have the duration is more here for unexplained chronic diarrheas. Here it is only 15 days or more. So there is slight difference that you will be seeing within the clinical staging of an adult and children in terms of the duration, number one, in terms of progression of the disease, and third is there are certain OIs. There are certain differences in the staging between children based on the extent of the infection. Next slide. So stage 3, again, you have certain hematological manifestations like unexplained anemia. And here you have like symptomatic lymphoidentistitial pneumonitis, chronic HIV associated lung disease, including bronchiectasis. This is again a very important thing. Once a child with no HIV status having a chronic bronchiectasis, we should be referring those patients to HIV test, children for HIV testing. And remember one thing, in a setting where you definitely require some tools for referrals for HIV testing, if any of the patients are coming within the OPD, if you're sitting in some other OPD, of course in ART it's all HIV patients, but somewhere else, this clinical staging will again help. If somebody is coming with such infections, we need to trigger and refer them for a HIV test. Next slide. So stage 4, as I told, it is a wasting syndrome, PCP, severe bacterial pneumonia, herpes simplex infection, where it is disseminated, esophageal candidiasis, extrapulmonary TB. So these are all, again, which requires some lab support here. Next slide. Like the Kaposi, CMV, HIV encephalopathy. You can just read for a half a minute for yourself. And mostly stage 4, there is no much variation between the children and adult because they are again considered there. Just you see in terms of disease progression, they may differ, but as an opportunistic infection, yes, they belong to the same stage. Next slide. So again, Hodgkin's, non-Hodgkin's lymphoma, these again are in stage 4 infection. Next slide, please. So I think you would have paid some attention until now. I'll just break the monotony for a while. So we thought that we will just have some photographs shown in this session. And we almost have 163 connections. At least 150 of them will be active. So we will see how many responses we get on the chat. Here you don't have a poll, but all the respective centers who are there should keep a tab, and then please punch in your responses as you see the slides coming in. We have 6 such slides. Next slide, please. Yeah, so what do you see? Use your chat box. What is the clinical stage of this particular infection that you're seeing? You're free to respond and say what is this infection and staging of it. Yes, already you've started answering. You can correct your answers also. Very good. Already 30 answered. Yeah, 160 connections. So that's all, we have active members now. Very good. So what is that infection? Can everybody unmute and just speak about?
Herpes simplex.
Yes, yes. Very good. Very good. Next slide, Sweta. Next slide, please. Sorry, please respond to this. Herpes zoster is correct, but what is the stage? Next slide. Yeah. So what is this now? What you're seeing, that cardioid precipitate in the oral cavity? Which
candidiasis.
state?
Sir,
Yes,
oral
oral
candidiasis
candidiasis.
is stage 3.
Very good, madam. Very good. Very good. Okay. Next slide.
Oral plus esophageal candidiasis, stage 4.
Anybody to differ with madam? Differ with madam? Yeah, stage
Esophageal.
4. Very good. Yes, ma'am. Yes. Next slide.
Should we?
Yes, yes.
Oropharyngeal would be probably.
Yes, yes.
We need to.
You'll need to further see it. Okay. You'll see the tonsillar pillars, all that on the clinical examination. Very good, sir. Anand Rao, sir. Next slide.
Cervical
what do you say?
lymphadenopathy, sir.
Very good. Anybody else want to defer this answer? Okay, which stage is this now?
Stage 4, sir. Stage 4.
Somebody may say this is persistent generalized lymphadenopathy.
It looks like an NHL, so we have to do FNAC and then confirm it.
Yeah.
Very
We
good.
will do a FNAC and confirm it, and most likely it is.
NHL.
Yeah.
Okay. Good differential diagnosis. Anything else? Yeah, bucket stage 4. Very good.
Maybe lymphoma.
Like, yes, ma'am. So all these are again stage 4 only.
Yeah.
So why is it important is that we know that we are dealing with something which needs a further diagnostic workup.
Yeah.
And other very important thing that all of us need to understand is when we do this clinical staging, there are certain infections for which definitely ART only is the answer. For example, you have pruritic papular eruption, severe seborrheic dermatitis, and all. For that, the only answer is starting
ART.
immediate antiretroviral therapy.
Yeah.
Next slide. Yeah, so coming back again, so until here we understood we need to have a good thorough clinical examination, we need to have a good history taking, and then we staged the patient. Now again, when you do a good clinical examination, we want to understand whether the patient has any advanced disease, clinical features suggestive of advanced HIV disease. So not just having a CD4, but we also want to see some critical signs and symptoms, whether they are part of it. For example, we should definitely actively ask every patient for any signs of headache. So if there is any sign and symptom of headache, again, we need to ask for the severity. Then you need to look at respiratory rate. So if anything abnormal in all these, what is just put up front of you: temperature, respiratory rate, heart rate, having oxygen saturation lower than 90, altered mental status, neurological things. So all these will require an immediate referral in terms of to further evaluate. No, if we are able to do, that's well and good, but always these are called some of the danger signs where we require a good systematic and systemic examination, where we may not have time and resources to do everything. So this again are signs of serious illness which are considered as part of the advanced HIV disease package. Next slide. So who are those again we label as advanced HIV diseases based again on there are two things that we need to understand whenever we start looking at advanced disease management is what is the CD4 count of the patient. If it is less than 200, yes. And also if you see the definition in our guidelines, it says if the patient is seriously ill. So what is the meaning of seriously ill? All those clinical features that you have seen in the prior slide, if something is abnormal there, that again calls for a serious illness, or if they have a stage 3 or stage 4 infection. So this again becomes paramount important, that when you know the patient is having stage 3 or stage 4 condition, you're dealing with a person who requires that advanced disease package of services. So that again becomes a rationale why we should keep following the why we should keep staging the patient at all the times whenever they are at the ART center. Now, if you look, there is a slight difference between children and adults. In children, all less than 5 years of age children are considered as having advanced HIV disease, except if they are on treatment for more than 1 year and they have a viral suppression, then we don't actually put them under this. So except with this exception, we say that all children less than 5 years of age should be considered in all practical sense as having advanced HIV disease. Children older than 2 years who have been receiving, that's what I told, more than 1 year and are established on ART and clinically stable should not be considered as having HIV disease. And any patient who is coming after interrupted therapy, that is after our loss to follow-up, should again be considered as having advanced HIV disease, because we cannot really monitor based on the previous CD4 count, based on the previous drug history, we cannot categorize that patient. Next slide, please. Yeah, so nutritional assessment again is an important one. We will have a very detailed discussion because in the current guidelines, we have a separate chapter on the nutritional assessment and what is the counseling aspects of this. But here what we will try to do is, what are those critical things that we need to do while doing an assessment, specifically in children, is the anthropometric measures that we need to do, an assessment of edema, whether it is bilateral, unilateral, and dietary or food history. Next slide. So again, this is this was a limiting factor. If you see some before our operational guidelines and before we had an algorithm for advanced HIV disease, for rapid ART initiation, we were mainly banking on the baseline investigation. Until the baseline investigations are there, we were not starting ART. But with the algorithm from the National AIDS Control Organization, it becomes now very easy to assess a patient, and if there are any triggers, only then we are delaying it, but not just because of unavailability of some investigations or timely if they are not there on the same day. So what we definitely want the patient, what we definitely want prior to initiating ART is having a hemogram and fasting blood sugar, blood urea, bilirubin, VDRL again as part of the investigation, CD4 and a chest X-ray. So these are all called as essentials. There are certain centers that may be doing other investigations like ultrasound and all as part of the hospital services they have. But again, when you keep doing more investigations, there is more and more time required. Number one, if you are doing some, again, certain investigations like ultrasound and all, they require a specific appointment process. So these again will delay ART initiation, and they are not again an essential package of tests that we are asking the patients to have prior to starting ART. Others are good to have, but these are must, and we need to ensure that they are there. Go to the next slide, please. Yeah, see the bottom line, what we are saying is non-availability or non-feasibility of any of these should not delay initiation of antiretroviral therapy. And the other tests that you are seeing here, for example, RK39 that we are using for Kala-Azar in endemic areas. And you also have certain other tests like liver function, lipid profile. All these are good to do. But if the patient is not affordable, number one, or not available within the public sector, and we should not limit the patient or we should not delay the patient initiation of antiretroviral therapy. Next slide. So earlier we had in our prior guidelines, in the operational guidelines, we have seen 8-point tool for the counselor prior to starting antiretroviral therapy. Similarly, here we are looking at what are those activities that the ART center staff will be doing when the patient is getting has come to our ART center. So on the day one, usually what activities we do with the patient is the registration, having a good medical history with a 4-symptom screening, any support structures required socially. We recommend for condom and daily use. And then we initiate cotrimoxazole preventive therapy based on the CD4 count. And we also refer for the baseline laboratory workup. And if all things are there, we initiate the patient. And he or she should understand that the antiretroviral therapy is a lifelong therapy. Is one important single driving message we need to give to the patient, because it's not one day, 2 day, it is a lifelong therapy. Next slide. Then before the follow-up visits, that is, if a follow-up visit is a monthly visit and suppose the patient did not have investigations, possibly we may have a repeat visit in the first 15 days whenever the investigations are available to reassess, and if required to change the therapy or include something else as a preventive therapy too when the investigations are available. So, but if the patient is having all the investigations, everything is done perfectly, and you send the patient home, we could also use our counselors to start calling these patients in the initial 3 to 15 days after initiating ART, and actively ask the patient for any side effects that are hurting the patient, okay, or any other issues related to taking medications. So this is again part of our guideline, is that we need to call the patient within the first 15 days, number one, to understand any challenges of antiretroviral therapy, challenges of well-being. Number three, also we want to understand that the patient is taking drugs or not. So this process of calling the patient in the first 15 days operationally is very important, both from the care provider point of view and the patient point of view. And subsequent visits after initiating ART, we need to look for all these. Okay, next slide. So with this, to just wrap up in 2 minutes of what all we have seen in the first and the second part of the session. First part of the session, what we are seeing is how to offer a HIV test, whom do we offer, and how do we interpret the HIV testing results. So the key here again, what we have heard from ma'am was that if somebody is a key population and you are getting a first test positive, second test negative, third test negative, please in the high risk population, the report will read as indeterminate, and there should be a second a follow-up test to be done. And coming to infant diagnosis, we know it again, 18-year, and then there we are using the total nucleic acid testing as part of the national program now. Then as we came forward, we have seen about while starting antiretroviral therapy, it becomes important to have clinical history taking. Then you take past history, a clinical physical examination, and then the laboratory workup. So with this, we have completed. Let's see what all we have done in this session and the post test now. So again, I thank you all whoever was responding to those questions on staging. I want you all again to take up this post test. It's the same thing what we have seen as a pre-test. Next slide.
Yeah, thank you so much, sir. I'll once again read the case scenarios and then we can start the e-poll. The first case scenario is adult person X has cough with expectoration for more than a month, fever for more than a month with severe diarrhea. Case scenario 2, adult person Y is asymptomatic and has laboratory report confirming HIV-1 infection. Case scenario 3, adult person Z had history of extrapulmonary TB and molluscum contagiosum in the past and has a CD4 count of 350 cells per milliliter. Kiran sir, can we now start the e-poll, please? Thank you, sir. Requesting all the participants to please attempt the e-poll. There are 4 questions in all. This is a single choice question, so each question has one answer. Please scroll through your screen and then attempt the questions. Dr. Ramesh sir, do I read the question answers for the second, third, and fourth?
Yeah, so the first question is what Shweta had just read is for the first question.
Sorry. Yeah, so from the first question, please, from the given case scenarios, you have to decide who has the HIV infection. Is it person X? Is it person X and Y? All 3 of them, or is it person Y? The second question is, which of the following are recommended as per NACO or as per NACP to confirm HIV in a child less than 18 months of age? Your choices are TNA PCR, quantitative PCR and TNA PCR, DNA PCR, or rapid antibody test. The third question is, a client from a key population group had first test positive and the second and third test result as negative. How do you interpret his test results? The choices given are negative, positive, indeterminate, or intermediate. The last and the fourth question is, TB pleural infusion in PLHIV is categorized as WHO clinical stage 3. Is this true or false? Requesting everyone to please attempt the post-test questions, the e-poll. We'll take questions from the participants after the e-poll. We have another 2 minutes for the post poll. Kiran sir, we can now end the e-poll.
Can we share the result, ma'am?
Yes, you can share the result and end it.
Okay.
I'll quickly run through the answers for these questions. For the question, which of the above case scenarios who has HIV infection? It is person Y. For the question on which test has to be taken up for confirming HIV in a child less than 18 months of age, it is rapid antibody test. For a client from a key population group whose first test is HIV positive and the second and the third test is negative, how do you interpret his test result? The test result is indeterminate. And for TB pleural infusion in PLHIV is categorized at WHO clinical stage 3. This is false. Over to you, Ramesh sir.
Yeah. So any questions? I think somebody raised and question one, most of you, I think what you have thought is if a person is having molluscum, it should be HIV. I mean, when you were putting that question, I think that is what your frame of mind was. Not everybody with molluscum is HIV positive. So it was very clear. I mean, what the bottom line, what you need to understand is that apart, you can have any disease on earth, but if you do not have your laboratory diagnosis of HIV as a HIV, then it's not HIV. So there is no clinical diagnosis of HIV. The clinical acumen will only help you to refer them for a HIV and to confirm their status. But just having all the clinical stage with him, but if a HIV test report is negative, it is negative. So that is the only point that we thought we will drive here, that CD4 report, all these are not part of confirming HIV diagnosis. And the way you will know a person has HIV is only through a laboratory support. And the second question that has come up, most of you, the pleural effusion is extrapulmonary TB. It should be stage 4, but it is stage 3 there. So what they have given is a wrong one. And it is a total nucleic acid. I think the question number 2 should be, it is a total nucleic acid assay that we are doing. So it is not a quantitative one, it is a qualitative test. That's what ma'am also was saying. It's a qualitative one, and we do a total nucleic acid assay. The difference between a quantitative and a qualitative assay is the quantitative is the viral load that we get. Like, for example, the PCR. How much is your viral load? If I ask you that question, you will tell me quantitatively. Sir, it is 1,000, it is 2,000, it is not detectable at all, it is TNA, something. So you're quantifying it. But if it is a qualitative, you either say it is present or absent. So there is a difference between a qualitative and a quantitative test. So for patients with within the HIV program, what we say is that less than 18 months of age, we do not do any rapid test, but we the current guidelines say you do a TNA PCR and confirm the diagnosis. So I think 1 will be the answer for question 2. And indeterminate, yes, that's correct. Any other questions? I saw one hand raised from Tirupati. Yeah.
Participants can now unmute their mic. In case there are any questions, requesting participants to please unmute their mic and ask the question. You can also type it in the chat box.
Each time I keep on posting in the chat box to please share the PPT, but generally what happens is the YouTube link is shared. The PPT is much better, sir. We don't have to, if there's a PPT, we can easily refer to it, whereas the YouTube, we will have to go through fast forward and backward.
Ardra, sir, I will do it personally for you, don't worry.
No, in each session I'm posting it, but we only post the
Sure,
YouTube link, sir.
We will do that, sir.
Even NDLS, there is the same issue, sir.
Okay.
Okay, thank you.
Thank you.
Any questions from the participants? please feel free to unmute yourself.
Sir, good afternoon. This is Dr. Swami from Mysore.
Good afternoon,
Hello.
sir. Please go ahead.
Yes, sir. Yes, sir. Yes. Yeah.
Yeah. Like we have one child who is now 13-year-old boy. Initially, the 6 weeks and 6 months DNA PCR or DBS were negative. Positive. He was started on ERT. And 18 months antibody test was negative.
Right.
But those time the guidelines was just to continue ART. So we just continued the ART. Now the boy is 13-year-old. Now the guideline says we have to repeat all the tests, like including the TNA PCR and antibody test and not antibody test, the ELISA test and viral load. So we have done the viral load and this ELISA, both were negative. That means that viral load came TND and ELISA came negative. But TNA PCR, we don't have provisions, so we have sent it to Bangalore Nimans. But almost 1 month we didn't get the result. Then I spoke to the in-charge person there. They say we don't have any recommendation from the NACO or from any authority to do for TNA PCR for the above 18 months. So what to do, sir?
Okay. So, sir, you are from JSS, huh?
No, Asha Kirna.
Okay, you're from Asha Kirna. Okay, Dr. Swami. So what to do is, I mean, for us, the Pediatric Center of Excellence is, I think, Indira Gandhi Institute, right? Bangalore. Can you refer that case through that? Through that, if you refer, then possibly, because when a SASAP makes a recommendation, even if it is within or outside the guideline framework, whatever is best possible, they will be able to do, rather than they will not take a direct recommendation coming from the ART center, sir.
Okay, right.
Yeah,
thank you.
Just go through Dr. Sanjeeva, and then I think it will be done. Yeah.
Thank you, sir. Thank you.
Yeah.
In defining advanced HIV case in children, why didn't they include viral loads, like log 5 or log 4 criteria, viral load criteria?
Even here, because we are not seeing anybody, the advanced disease package, we are not seeing in already a treatment experienced patient, no? As while we want to initiate somebody on ART, we are looking at whether this patient has an advanced disease or not. So at that point of time, we will not, I mean, most of them will have a higher viral load because they are not treated. So that will not make any much sense of including a viral load prior to starting antiretroviral therapy.
So one more patient, he was an adult patient. She was actually the viral load was TND and CD4 was about 800 plus, but she was losing the weight, and she had multiple lymph nodes in the cervical region. We did FNAC. FNAC showed non-reactive lymphadenitis. Just reactive lymphadenitis. And we did a biopsy also. Biopsy also didn't show any signs of either lymphoma or any signs of tuberculosis. Then we just followed the patient almost a month. We tried all the investigations, but nowhere we were able to find why she was losing the weight. Then we did a month later again. We did one more FNAC in a different lab. Then it showed tuberculosis lymphadenitis.
Okay, yeah. So I think one lesson as undergraduates, what we have learned is FNAC is again a very not so sensitive investigation, because it depends on where you actually push the needle. So if it is going through the other part of the node, and if I don't touch the other actually infected node, then my chances of getting the yield is very low. So this is not this is a very specific one, but not a sensitive investigation of choice for specifically if you have to diagnose something in the lymph node. Yeah. Okay, then. Thank you all for your good questions and participation. Yeah.
Thank you so much, sir. Thank you, Chinmay ma'am. Thank you, Anuradha ma'am. Thank you, Ramesh sir. And thank you to all the participants for patient listening.
Shweta ma'am, feedback.
Yes. Oh yeah, feedback. Sorry. Requesting participants to please attempt the feedback questions on ePoll. Requesting all participants to please attempt the ePoll. These are feedback questions for the session. The first question is, I found the session conducted under the National Guidelines for HIV Care and Treatment 2021 series to be relevant for my practice. Do you strongly agree, neutral, disagree, or strongly disagree? The second question is, the queries I had about the topic were addressed in the session. The choices remain the same. The third question, the information presented during the session was clear and easy to understand. Choices remain the same. The last question, on the scale of 1 to 5, where 1 is very poor and 5 is excellent, how would you rate the session conducted under this series? Please continue attempting the ePoll for feedback. For information, next sessions are planned on 6th of July. The topic is assessment of adults and adolescents with HIV infection. And on 7th of July, it is advanced disease management and prevention of opportunistic infections. Timing will remain the same, 2 to 3:30 p.m. Kiran sir, we can end the feedback ePoll now. Once again, thank you to all the participants for patient listening. See you on 6th of July. Thank you.
Thank you.